Yes, totally. You can start now.
Okay, thank you. So, good morning, everyone. So, today we're going to talk about hospital care for older adults. I'm Jenny Lee, a geriatrician from AHNH Hospital. So, in geriatrics, we cannot talk about the one man, one disease model because for older people, usually they have many chronic diseases. So what we talked about would be the functional level of or a collective description of the older person's condition, which we call frailty. So frailty syndrome is actually a syndrome that predicts poor clinical outcomes. So as a person gets older, many of the physical systems, physiological systems, including immunity, including the skin conditions, as well as all the other organs, will have a reduction in reserve. Most typically, you will see that the vital capacity of the lungs will reduce by 50, or eGFR in the renal system also will reduce after the person gets as old as 60. Then automatically by age, the renal function will decline irrespective of any chronic illnesses. So this is what we call a loss of physiologic reserve. And the result of this, the collective loss of reserve will put the individual more vulnerable when anything, any disturbance occurs. For example, just a very simple URI infection or urinary tract infection or even a fall will trigger the breakdown of other systems. And this is important because this results in what we call the atypical presentations of diseases or illnesses in older people. In a young person, for example, if the person develops a urinary tract infection, they will typically have dysuria, they will have fever, and then they can also speak about the symptoms, and it's very obvious that the diagnosis would be a UTI. However, in an older person, very often they present with non-specific or unrelated problems like dizziness, poor oral intake, or even a fall and a fracture. So this is the result of the frailty and also the reducing physiological reserve in multiple body systems that I've mentioned above. When a patient has a sepsis, because of the sensory impairment or the cognitive impairment, they do not really detect the dysuria. But what they will present would be perhaps urgency, and when they hurry to go to the toilet, they lost their balance because the balance system and the brain is also disturbed. And then perhaps when they get up from the toilet, they get dizzy because the cardiovascular system has a lower reserve than normal. So what result would be when they get up from the toilet, they fall. And the frailty syndrome is also important when we treat a patient and organize our treatment plan, or even to predict the prognosis of what the treatment outcome or rehabilitation outcome will be for any one individual. In this graph, you see that for those who are robust and managing well, they pretty much will resemble the recovery course of a normal adult. They will have a short time of recovery and then they will back to the normal selves. But for those who have a moderate frailty, these will be the people with several chronic illnesses, but they are quite well controlled, and they do not have cognitive impairment, and they do not have disability. So these people, when they have an acute illness, they will take a longer time than a normal adult to recover. And very often, when they do recover, they had a lower functional level than before. For those who are very frail, this would be the typical old age home residents who are already chair bedbound, have some sort of cognitive or physical disabilities. When they had come across the stresses such as infection or fall or hospitalization, they very often take a very long time to recover, and they will never be back into independent functional level. And sometimes some of these people will die in a hospital. So this is a typical OH home resident, and in fact, she looks better than most of our current OH home residents who are probably on tube feeding and also incontinent and could probably not even sit up. So when we mention decreased general condition, this is a condition that's invented by our A&E officers in Hong Kong. What we mean when they write this on the admission slip is that it's usually from OH home. The OH home residents, typically they can't really tell you what the history is, and the OH home staff would have been gone by the time the patient reaches the ward. So you have no history at all from the patient or from the caregiver. So what you have to do is you use your clinical sense and your physical skills to detect what is the reason for the admission and also for the decrease in general condition. It can, the presentation can be anything from mental dullness, delirium, or not eating well. And the diagnosis can be anything from stroke to sepsis to just constipation. So you really have to do a very proper physical examination relevant to this sort of older people. So in the physical examination, what additional things you would have to do when you have this kind of patient on your hands? So we'll do an abdominal examination. But apart from detecting just the usual liver, kidney, or detecting for acute abdomen, I suggest you to do a palpation in the suprapubic region, because that's often where you can find a distended bladder, which can be the reason of the admission, urinary tract infection, or constipation obstructing the urine outflow tract. And I would also advise you to do a proper joint and skin inspection, because sometimes sepsis or a fever may not be related to chest or urinary infections. They can be related to arthritis, arthralgia, and also cellulitis, or even gangrene in the toes. So when someone presents with chest pain or chest discomfort, apart from the ECG and the detection of ACS or ischemic heart disease, always try to palpate the chest wall as well. Look for tender spots over the ribs. Sometimes they might have a contusion, and that might be the chest pain, the origin of the chest pain rather than the cardiac problems. And then correlate what you see with the past medical history in the CMS. Because sometimes the presentation of dullness or not eating well can actually be a stroke. So check that both sides of the limbs are moving, and check that the person didn't have a stroke at this juncture. So looking at the feet for gangrene, looking at the pressure points such as the sacrum, the heels for any cellulitis or even pressure injury evidence is also important. And remember, look at the configuration of the patient lying on the bed. It is not uncommon to discover what we call a care fracture or spontaneous fracture that has not been detected either in an OH home, at home, or even in the A&E department. So it is possible that a malaligned knee or hip can be a unnoticed, undetected fracture, and this may be actually the underlying diagnosis. So anything actually, not only medical things, but orthopedic things or surgical diagnosis can be possible in this kind of patients who have a very poor presentation of history. If the patient has give you any suspicion of mental dullness, coma, or confusion, then always do a hemostick to look for hypoglycemia or hyperglycemia, and also check the urine for toxicology, because medications can be dispensed or given to wrong patients in an OH home where the environment is quite crowded. And then if you think the patient has a very high, if they look fishy, for example, they are dull, think about CO2 narcosis, because in the ambulance they are used to be given very high flow oxygen, and sometimes people with COPD obviously are prone to CO2 narcosis, but there are other people who have deformed chest wall due to kyphosis, due to osteoporotic vertebral fractures. They might also have restrictive lung disease that has been undetected, and these may also be prone to CO2 retention. So in an observation of any X-ray where the patient is admitted, always try to look for other things other than the things you are interested in. For example, if this is a KUB, then or abdominal X-ray, we would be interested in looking at the bowel shadows or the rectal shadows. We would have missed this kind of hip fracture. So in fact, this is a patient who refused to eat, who has been eating poorly. But the reason is not anything medical, it's an orthopedic problem. And when you have, this is rarer nowadays, we used to have people with very deformed nails or fungal nails. And then when the oximeter are put on these fingers, they would falsely give you a very low saturation reading. So be very cautious when you are facing a patient who cannot give you proper history. Anything can be found in this patient. So there are some common pitfalls when we are dealing with patients who cannot communicate it very well. And for example, we often forget to give medications for pain relief, or a patient presents with diarrhea, but in fact, the patient is being put on regular laxatives. So this is the reason for the diarrhea. Some drugs we should be stopped when the patient is put nil by mouth. For example, oral iron tablets can be very irritating to the stomach, and in fact, it can cause gastric ulcer. Some anti-dementia drugs like cholinesterase inhibitors, they're cholinergic. They stimulate the stomach to secrete acid, so they will be very irritating on an empty stomach. So these should be stopped. And other drugs that can cause problems would include metformin and SGLT2 inhibitor for diabetes. For metformin, sepsis patients or patients who are ill are particularly prone to lactic acidosis. For similar patients, if they are on SGLT2, they will be prone to ketosis. So these drugs should better be withheld during an acute hospitalization. Excessive O2 supplements we have discussed before, and elderly being having a very poor renal function in general, and also a poor in homeostasis and fluid balance, they are very prone to the side effect of our IV fluids, such as hyper or hyponatremia, and also fluid overload, because they often cannot excrete all the IV fluids we give them. So when you are having very frail patients who have been repeatedly admitted to hospital for infections, think about the multi-drug resistant organisms that are very prevalent nowadays in the hospitals. Recurrent antibiotics at the end of life for such patients are often more of a problem, causing MDROs than a help to treat their infections, because that would mean recurrent infections actually is an end-of-life event, because the immune system is also having very low reserve. So a common sepsis would be aspiration pneumonia, what we call, or sometimes in A&E notes you'll see sputum retention. So this is a picture of somebody who is having a fees examination, which is an endoscopy through the nose, and then it looks at the airway and also the entry or site of the trachea. So this is what a normal patient should look like after a swallow. This is a less normal patient. You'll see that the stain, the colored substance that he has been trying to swallow. After the swallow, some pooling has occurred in the piriform fossa. And this is a very dysphagic patient. You will see that after a swallow, a lot of the remaining of the substance are still within the piriform fossa and also above the epiglottis. So when the epiglottis opens or when another swallow comes, then this amount will overflow right into the trachea. So this is the cause of the aspiration pneumonia. However, not everything that's aspirated will cause a pneumonia. For example, we have often aspirate our saliva or even some of the foods that we're eating when we're talking and eating at the same time. So if we have a good gag reflex, we will cough those substances out and protect our lungs. So some of the key points regarding what we call sputum retention or sputum sound in some patients. It does not always mean pneumonia. So do not treat these patients automatically with antibiotics. Always look for other signs of infections first. For example, increase in white cell count or even decrease in white cell count, because sepsis in elderly persons can be associated with a reduction in white cell count instead. And for example, a fever, or consolidation on a chest X-ray, or you can hear some change in the breath sounds when you auscultate. So always start antibiotics when you have evidence of sepsis, not when you hear something in the throat of the patient. And these are some of the signs that you can actually detect who is very likely to have aspiration pneumonia, even from afar. So these patients typically would have an extended neck, opened mouth, which they cannot close, and they would often have a history of late dementia or past severe stroke. One of the tips that I can give you to reduce the oral secretions or reduce these sort of pooling at the back of the throat would be to use some anticholinergic drugs to reduce the secretions. So the hyoscine or buscopan is the most common drugs that we are using nowadays for patients who are very, very prone to aspirate their own saliva at the end of life. I was talking to some intern yesterday. We were having training of interns, and I asked them if they have a patient with aspiration pneumonia, and after they refer it to the speech therapist, the speech therapist say that they have a high risk of future aspiration again. So what would the management be? And all of them mentioned that they are going to refer them for tube feeding. So before we start somebody on tube feeding, actually we should be looking at evidence of what this kind of therapy can do for these patients. So are they really useful? So we look at the literature, and of course, a randomized control trial of this sort would be very difficult because the patients cannot give consent and they are all at the end of life. So what we did is to look at the evidence from cohort studies. In fact, if you look at literature, there is absolutely no evidence to suggest that tube feeding or even a gastrostomy feeding can prevent aspiration pneumonia and prolong life. So why is that? Now, before we look at what careful hand feeding is, I want you to think about what the feeding tube does at the back of the throat. So the feeding tube only is being changed every 4 weeks or so. And this is a foreign body at the back of our throat. So in the mouth, we have bacterial colonizations, which I'm sure you know. But for someone who is going to have tube feeding or dysphagia or demented, their oral hygiene are typically very poor. So in some place where the hygiene is very poor and a foreign body is placed for 4 weeks, there will be definitely a lot of bacterial colonization on that feeding tube. The feeding tube goes down to the esophagus, but the esophagus is very close to the entrance of the trachea. So with the saliva, if we are not giving any food orally, the patient will still have saliva secretion, and this saliva will carry the colonized saliva fluid and goes down to the trachea with the feeding tube. So this is actually a risk factor for aspiration pneumonia rather than a protective device for aspiration pneumonia. So despite all the nutrition that we can deliver regularly via the feeding tube into the patient is having more frequent episodes of aspiration pneumonia compared with those who are on careful hand feeding, because there are no foreign body, and careful hand feeding means that you observe the patient carefully when you are hand feeding them. So if the patient starts to choke or cough, we will stop and then we'll encourage multiple swallows to improve the clearance of the posterior pharynx. So this is actually more safe for the patient and definitely more comfortable and more ethical. So careful hand feeding has now become the most prevalent recommended therapy for advanced stage dementia patients or stroke patients with severe dysphagia. Of course, for patients who have an acute stroke or who have an acute illness, who you think they will stop if they are not safe for oral feeding just for a very short time, then we should start nasogastric tube feeding to guarantee their nutrition, which will improve their recovery. But for patients whom you think they should be declining towards death, then careful hand feeding is definitely the thing to go more than tube feeding. Now, electrolyte disturbance is also very common in elderly or tube-fed patients because the control of their physiology system, the renal function usually is borderline. So hyponatremia is a very common problem in patients who are tube-fed and also in elderly patients, usually older than 85 or 90, who are orally fed. Why is that? Well, for oral feeding patients, in the common health concept, we apply our general diet recommendation to our middle-aged people. So we suggest low sodium, low fat, and low salt diet. But when we are going to the extremes of age, we must remember that the intake amount are smaller. When you look at older patients, you notice that their appetites are smaller, so they actually eat smaller. And therefore, their intake of food and sodium and salt are actually much lower than the usual adults. So when they are having low sodium intake for a long time, then they will suffer from hyponatremia just due to nutritional deficiency. So this is very reasonable for those who are on oral feeding. You may be asking, well, for tube feeding, didn't the dietitian calculate very carefully according to their body weight? So they should have the normal amount of calories, proteins, and minerals that they need every day. So why do they still come in with electrolyte disturbance? If you remember, that all these feeding formulas are produced either in the United States or in European countries. They are not specially built for the Asian population. So in the United States and European places, typical elderly would be very big, 60 or 70 or even 80 kilogram men is their standard. So these people will be taking at least 2 liters of the feeding formula every day. The feeding formula is therefore calculated based on a body weight that is much heavier than our local Chinese population. So the sodium level, the protein, and also the calories are all calculated based on a 70 kilogram person. So when our elderly, when the dietitian calculate, they only calculate the fluid amount and also the calorie intake based on the body weight of the patient. The sodium content, they cannot modulate. So for someone who is perhaps having 35 or 40 kilogram, that would be half the weight of the European patient. And they will be taking only half the amount of sodium every day compared with the European or American patient. And do remember that the mineral requirement, sodium requirement, is based on a person and not on your body weight. This is different from the calorie calculation and also the fluid calculation. So this person on tube feeding is just like the person on the older person on oral feeding. They are taking half of the sodium requirement every day for a long time. So this is why tube feeding patients are also very prone to have hyponatremia. So one thing with hyponatremia is that in the kidney, we exchange sodium with potassium excretion. So when you have very little sodium in the blood level, the potassium cannot be exchanged to get rid of in the urine. So what happens is that you will see a combination of hyponatremia and hyperkalemia in the blood of these patients. So the solution is very simple. You increase the sodium intake. So for those who are on oral feeding, you advise them to eat more salt or eat a salty egg or salty fish more often. They would be very happy with this. For those who are on tube feeding, we prescribe salt tablets, sodium chloride tablets. So salt intake would be a very important entity for the nutrition of older patients, and sometimes they can actually cause hospital admissions. Of course, there is also a problem that is called age-related SIADH in the very old, because the pituitary function is also going. So and also the kidney function is going. So the ADH secretion may be inappropriate. And also the response of the kidney tubules to ADH can be inappropriate. So this combination also results in a generally lower lower sodium level in the blood of older patients. It's very common to see, for example, sodium of 130 or 128 in very old patients. And however much salt you give them, they will always remain that low. So this is the difference between a very old patient and a younger patient. Now, refeeding syndrome is also another important problem. It doesn't only happen in surgical or ICU patients, but it happens very often in older patients, because in the long run, they have been malnourished. And during hospitalization, they may have NPO orders or new by mouth for several days. So when we give them full diet, especially tube feeding diet, they will be subjective to refeeding syndrome. So this is the mechanism of the refeeding syndrome. So when you have catabolism or chronic malnutrition, you have decrease in insulin and increase in glucagon to maintain your blood sugar. So there are a lot of breakdown of glycogen, protein, and also the vitamin and mineral nutrition levels dropped as nutrition intake is reduced. So when we are giving them real food again, there are a lot of carbohydrates, and this will increase the insulin secretion to compensate for the hyperglycemia. And a lot of things will therefore occur in the body. For example, of course, protein synthesis increase, that would be a good point, glucose uptake, but there will also be an increase in the thiamine usage and also intracellular shift of several minerals, including phosphate, magnesium, potassium. So this is what we actually see: thiamine deficiency, hyperglycemia, and also low phosphate, magnesium, and potassium in refeeding syndrome. So when we start undernutrition or someone who has not been fed food for quite some time, a patient on real food, then we will have to replace these entities before we start the feeding. So we typically give them thiamine supplement, and then we also measure these electrolytes and provide supplement if they are needed. So this is the management for the hyponatremia. So poor oral intake is another very common diagnosis for hospitalization in older patients. Of course, with aging, there will be anorexia, and old people typically have smaller appetites. But there are other more malignant conditions such as cancer, chronic conditions such as tuberculosis, and GI tract problems, anything that happens from the oral cavity down to the anus, such as oral ulcers, dental caries. And of course, you can also have problems in the bowel, such as obstruction due to tumor and also due to chronic constipation. So this is very important, constipation, because it can cause a lot of conditions in older people. And in older people, if they have symptoms of IO, then ischemic bowel would be something that you would like to check for. Typical presentations would be atrial fibrillation, metabolic acidosis, sinus tachycardia, and poor oral intake or abdominal discomfort. So PL bleeding can also occur, or abdominal pain can also occur, and it can be due to diverticulosis or diverticulitis, which is again due to chronic constipation. So when you are dealing with somebody who is admitted with poor oral intake, apart from the usual blood taking that you should do, try to look for a change in the body weight, because this will be very useful if there is a marked decrease in body weight recently. That means something malignant must be going on. Usually it can be tuberculosis or cancer. So some of the hints you can get would be from the intake and output chart. Listen for bowel sound, for possible intestinal obstruction. Look for acidosis and atrial fibrillation, and also do a PR examination. An X-ray will be also important, but do not do the abdominal X-ray, the A-X-ray. The KUB would be more useful because the KUB includes the rectal region. And for example, in this X-ray, you see that there are opacities, roundish, like pebbles. So these are actually very well-formed hard stool in chronic constipation. You can see these stool shadows in the bowel and also in the rectum. So this is a patient with a chronic constipation, and this is likely the cause of the poor oral intake. The IO chart is also very useful. Apart from the side that describes how much the patient has been eating, I would suggest you to look at the other side, which says that stool frequency and also consistency and amount. So if you see somebody with multiple bowel opening every day, it does not mean that they do not have constipation. You must also look at the consistency and also the volume of the stool that the nurse writes here. For example, in this patient, the consistency is always soft or fluid, and then the amount is small. at most moderate. So this would mean that the patient can have what we call spurious diarrhea. Spurious means not true. So this patient is having multiple bowel openings because there are very hard fecal impaction above the anus or rectum. So only the soft or fluid stool can be passed out. And because they are fluid, the rectum cannot hold them properly, and therefore the bowel opening will become very frequent. So this is a patient who has a cancer of the rectum, which has nearly occluded the rectal opening. And this is why she is having spurious diarrhea. So when we did a PR, after looking at this chart, we did a PR and we found the tumor. So an IO chart is also very useful. And just do not think that people have a lot of bowel motions every day, do not have constipation. So ischemic bowel and rectal tumor are very tricky. So always remember these diagnoses. Another very common diagnosis would be fluid overload or congestive heart failure. Now, this is a case of an 80-year-old woman who had a recent hip fracture. And she came back in again after 1 week because of some wound discharge. And she has the usual chronic diseases. Now, she presented with shortness of breath and wheezing and desaturation. So this is her chest X-ray. It's a very congested X-ray. You can see she's obese. This is a sitting X-ray. And you can see despite it being a sitting X-ray, the heart is really very large. There is a possibility of some fluid in the costophrenic abscesses, recesses on both sides. So when we look at the laboratory results of this 80-year-old woman, we will find a lot of abnormalities. So this tells you that it is very difficult to dissect out which is her main problem. So usually for fluid overload, I wouldn't go for immediately to say that it's a congestive heart failure, because congestive heart failure is a diagnosis that you will have to perform echo on to determine. There are preserved ejection fraction heart failure and also reduced ejection fraction heart failure. So congestive heart failure would mean reduced ejection fraction. And we cannot say that without an echo. But there are other possibilities that can cause a fluid retention status. That would be reduced in or chronic kidney disease. So we look at the renal function of this patient. Well, we see that, as I mentioned before, they typically have a low sodium level. So this one has 130 sodium, but the renal function is fairly normal. So looking at the chest X-ray, we might think that, well, perhaps she has some heart failure. Yes, she could have that, but before we proceed, we should look at other causes of fluid retention as well. So the other causes I would look at would be the albumin level. I would immediately go to look at the albumin. You can see the albumin level is very low. So this is another reason for the extravasation of fluid into the third space, including the pleural, and also the lungs, and also the periphery. Another reason for a very low oncotic pressure in the blood vessels would be a very low hemoglobin level. She just had a hip fracture surgery, so she had a drop of her hemoglobin by about 2 grams per liter. So she only had around 9 here in her hemoglobin. So the combination of hypoalbuminemia and also anemia itself can already be a cause of her fluid overload status. Now she has many problems here, but she does have genuine fluid retention because even her serum osmo is low. So she also has a problem of SIADH perhaps, and she also have other liver problems. So the liver problem can be a cause of a hypoalbuminemia. So this case illustrates how difficult it is to determine how to manage an elderly patient who can have everything on her left arms being abnormal. So in these cases, what we can do is we have to determine or prioritize what we need to do first. So for this patient, we have gone through that. So for this patient, for example, her main problem, we cannot determine which organ or which system contribute most to her fluid overload. But the fluid overload is genuine. So we have to manage the symptom first. We have to get rid of the respiratory distress. So we will give diuretics for the fluid retention. And then afterwards, perhaps we will have to improve her hemoglobin status by iron supplement if she has iron deficiency after surgery. We might have to increase her nutrition or ask a dietitian to prescribe high protein supplements during her hospitalization or even after her discharge, because she obviously have a very poor albumin status. We may have to work up her liver, perhaps request for an ultrasound of the liver to see if there's anything wrong with the liver. Perhaps she has liver cirrhosis that's gone undetected. And we will have to request an echocardiogram and also do an ECG, look at her cardiac status. Perhaps she needs some cardiac drugs to improve the cardiac output. So these would be the directions that we have to go for at the same time for this patient who come in with one problem. So, but you see that all these requests and investigations, they take time. So you will have to determine or prioritize when these investigations can take place. You cannot keep her forever in the hospital to wait for the echocardiogram. You can keep her just for the ultrasound. And you will have to determine whom you would like her to see afterwards, the dietitian, the cardiologist, or just geriatrician yourself. So seeing an elderly patient is very often a problem-solving exercise, and it can be very complicated. Now, delirium, I think you have a separate lecture on delirium, so I'm not going to cover it today here. But just one thing about delirium is that it is very often caused by restraints we use in the hospital. The restraints are often there because we doctors prescribe some sort of therapy that required to be retained on the patient's body, such as oxygen cannulas, IV catheters, cardiac monitoring wires, Foley catheters, that sort of things. So as a geriatrician or as a doctor who works for all patients, I would suggest you strongly, when you do your morning rounds every day, look at the patient, check all the lines that are attached to the patient to see if they really have to stay there for another day. And if they don't, try to take them off and also request the nurses to reduce the restraints to a lower level as possible. So step-down restraints every day is also a therapy that we can use for older people. Identify and remove the cause of the delirium, and that would include our therapy and also our lines. And of course, when they are very confused in the evening, we want them to have a good sleep. We don't want them to be tied up. I would suggest chemical restraint rather than physical restraint. Chemical restraint is kinder. And for chemical restraint nowadays, we use a trazodone, which is a SSRI with sedative properties. Or sometimes we can use melatonin, which helps them to orientate the day and night better. Now, for non-communicable patients, we see a lot of these. Mostly they are demented patients. Now, there's one thing that I want you to remember is that cannot talk does not mean that they have no communication or that they are not a human being. Your pets at home, the dogs and cats and birds, etc., they have no speech, but I'm sure that you think they can communicate very well with you. So the same as these demented human beings who are our patients. So they have lost their ability to talk, but that does not mean that they are non-communicable. So they do communicate with us by their physical gesture or their body language. So clinical observations will be very important. So for patients who cannot talk, please do not prescribe PRN symptomatic drugs, because PRN means that they will have to ask nurses for the drug. So prescribe regular paracetamol for pain relief, and look at their wounds and also the IO charts. For people who have no bowel motions for 2 or 3 days, I would strongly suggest laxatives for those who are very old. And that would improve their appetite and also encourage them to move around and also go home earlier. So review the wound charts, ask the nurses for the pictures of the wounds, and ask the nurses whether the patient show any facial grimacing, or they struggle, or they yell or scream during wound cleansing or wound dressing. So these are important to judge the measure of analgesics that we need to use. It is not uncommon to upgrade your analgesics for just a wound to narcotics, for example, tramadol or even morphine. So regular symptomatic drugs for those who cannot talk, and look at your patients, touch them or try to move the limbs to see if they have pain when they are being moved, because they will have to have nappy change every few hours, and these will also cause pain. So, and minimize instrumentation. Switch your IV antibiotics to oral as early as possible, and bring down the oxygen, and also stop the cardiac monitoring as soon as they are not needed. Deconditioning is a condition that is not a reason for hospitalization. It is the result of our hospitalization. So deconditioning is a huge problem because they will delay the discharge of a patient, and it will mean also a very long stay for the convalescent bed hospital. So to prevent deconditioning is another therapy for us doctors. So how do you prevent deconditioning? We early mobilize the patient. You take off all the instruments that are attached to the patient and encourage the nurses to sit out the patient as early as possible. And you refer them to the physiotherapist and occupational therapist for training as soon as they are able to sit out and they look awake. And you might also need to explore the care support exploration. Right now in the hospitals, we have the post-discharge support or ICM nurses. So you can refer these patients to the CGAT team or COST team to see if they are suitable for post-discharge home support services. And you may need to determine whether they need an inpatient rehabilitation in Sha Tin Hospital or in other convalescent hospital, or they can go home and go to the day hospital for continued rehabilitation. So these are some of the things that you have to think if the patient in front of you is an elderly patient and they are coming from a home or from an OH home. So remember, as doctors, and most importantly, as doctors for all patients, relieving suffering is one of our main jobs. Most of them have chronic diseases that cannot be cured, but they do suffer, and pain is the most important symptoms that they can suffer from. These are often neglected, and analgesics are often forgotten in patients who cannot speak. So regular analgesics, please, and monitor the response and escalate if more strong analgesics are needed. And often, of course, look at the side effects of your drugs, constipation, GI side effect, nausea, etc. So I'm going to summarize here. All the patients are very complex. they have little reserve of every organ. So whenever you prescribe a drug, remember to check for the renal function, the body size, their appetite, to see if they can tolerate the drugs, whether the drugs are useful for it. For someone, for example, a simple drug like metformin, of course, it is a first-line diabetic drug. But then if your patient is a very smallish, thin, elderly lady with a very small appetite already, then metformin would not be the first-line drug for her. You will have to look for something else. They are very fragile. They are prone to side effects of all your drugs. They are prone to deconditioning during hospitalization. So you must mobilize them very early. Seek the help of other disciplines such as the nurses, such as physiotherapists and occupational therapists. The symptoms are often hidden. The symptoms presenting to you may not be the true reason of the underlying diagnosis. And relief of the suffering are equally important as curing the disease or healing the disease. Because they have so many problems, prioritize your treatment plan carefully. Some of the problems has to be handled later on, or even never at all. Someone who has a very short life expectancy, who is 104 years old, even if they have iron deficiency anemia, I wouldn't want them to go for a colonoscopy or even an OGD, which will cause a lot of suffering and maybe even risky for her. And look at the frailty status. The more frail, they are more prone to decline, and perhaps they were more prone to be deconditioned as well. So be certain to categorize them when you first come across them. Always aim to relieve symptoms and promote functional independence even during hospitalization. So I think this is the last slide. So thank you for attention. And if you have any question, you can raise your hand and or speak up. Okay, so Charmaine mentioned that I said metformin is not the first-line drug. Which diabetic drug would be chosen? Okay, for me, I will choose the DPP-4 inhibitors. They have a very low tendency for hypoglycemia. They are safe for the elderly. Even with reduced renal function, they can be used. I would strongly withhold insulin as a last resort because injections are something the elderly patients are very fearful of, and they often need someone to give the injections for them. So even with people who have reduced renal function, I wouldn't switch to insulin at the first instance. How do we manage full-blown refeeding syndrome? I think we need to replace the reduced electrolytes very rapidly. The magnesium, the potassium, and also the potassium, and control the blood sugar as well. And very often what we do is we titrate feeding when we first refeed them, because full-blown refeeding syndrome can be lethal. So when we start oral feeding, for example, tube feeding, we just start 50 ml per feed, and then maybe 4 or 5 feeds per day, and then we titrate up to 100 the next day, and so on. So it may take 3 or 4 or 5 days, depends on the condition of the elderly person. And for oral feeding, it's limited by the appetite, actually. So it's not as much as a problem as in tube feeding. Just in managing refeeding syndrome would be prevention is more important. So apart from the replenishing of the electrolytes or control of the blood sugar, the minimize the duration of nil by mouth period of your elderly patient is very, very important. To remember, try to start some sort of oral feeding after maybe day 3. This is my current practice. So any other problems? Are narcotics used in long term for elderly? Yes. Well, narcotic is sort of a double-bladed sword. So if a patient needs it, we will have to give it. This is the same as in cancer patients who are in severe pain. So if your elderly patient has severe pain, then there is no point to restrict the narcotic prescription. However, for an elderly person, typically have lower renal reserve. So when you are using morphine, which is a renal excreting drug, you will have to be more careful. Sometimes we can use other forms of narcotics. For example, tramadol is more commonly used than morphine. Morphine is more like reserved for extreme pain. And we often use a smaller dose because after a few days, the morphine level will accumulate in the blood. So a small dose is already quite effective. So any other person with questions? Okay, so I think we have run out of questions and time. So thank you very much again for your attention and hope you will all be very skillful in your future in dealing with all patients. Thank you and bye-bye.